And now we'll move on to our next session, which is James P. Ellison session. He got the Nobel Prize in Physiology or Medicine in 2018 for their discovery of cancer therapy by inhibition of negative immune regulation. And for this session, we have our chairperson, Dr. Asha Shah from Ahmedabad. Welcome, ma'am, and I request you to introduce our first speaker.
Thank you. It gives me great pleasure to be here chairing this session, and I thank Dr. Yash Patel and Dr. Mayur Patel for the same. And I also congratulate them for creating such a nice platform, and the conference itself is excellent, and I'm glad to be part of it. So we are now on the last session of today. As the speakers are all from US, it is a late session. The first speaker is Dr. Ajay Chaudhuri. He is Professor of Medicine and Chief, Division of Endocrinology and Metabolism, and Program Director of Endocrine Fellowship in the Institute like Jacobs School of Medicine, University of Buffalo. He is He's gotten a recognition as top doctors in America in Buffalo Spree 2020, Who is Who in Healthcare Business First Buffalo 2014. Hamsay Award for Best Abstract on Type 1 Diabetes also in 2014, and Outstanding Accreditation Award by Sunny at Buffalo in 2012. So I invite Dr. Ajay Chaudhuri. He's going to talk on CV benefits of anti-diabetic drugs. Over to you, sir.
So thank you for inviting me for this talk. Thank you to the organizers of SwasthyaCON. I was there 2 years ago and thoroughly enjoyed my visit to Ahmedabad and was extremely impressed by all the efforts that were being made to improve the lives of people with diabetes, not only in the city, but in the state of Gujarat. And it's with great pleasure that, I'm kind of looking forward to giving this lecture. As I said, it's a great time to be treating people with type 2 diabetes, because not only do we have agents now that can improve glucose without causing hypoglycemia and also causing weight loss, but now we have these agents that, independent of glucose control, is improving cardiovascular outcomes, which, as you know, is the commonest complication of people with type 2 diabetes. So in my talk today, I'm first of all going to briefly discuss the prevalence of cardiovascular disease in diabetes and bring in the concept of residual risk. Then I'll discuss the evidence behind the 2020, the American Diabetes Association guidelines. I'm sure that the guidelines by the Indian Association would basically be a little bit similar. And these guidelines, are basically going to focus on the management of diabetes with concomitant cardiovascular disease. We'll discuss some of the mechanisms for the cardiovascular benefits of GLP-1 agonists and SGLT2 inhibitors. And I'll focus on GLP-1 agonists more because I know you're having a couple of other talks for the SGLT2 inhibitors. And then we are going to discuss some of the evidence of the non-glycemic effects of GLP-1s, SGLT2 inhibitors, and thiazolidine ions from our department in the University of Buffalo. So what is the association between diabetes and cardiovascular disease? And we have known this, that majority of people with type 2 diabetes are going to die because of cardiovascular disease. As you know, type 2 diabetes is considered a coronary artery disease equivalent. And that's why even in somebody who has not had a cardiovascular event, if they have diabetes, we treat them with all the measures that we would if a non-diabetic had cardiovascular disease. We also know that stroke is increased, heart failure is increased. And as I mentioned, the coronary heart disease deaths are approximately 2 to 4-fold. Now, if we look back at the major historic cardiovascular outcome trials, that have been done in people with diabetes, before 2000. These were primarily trials that were trying to compare whether intensive glycemic control versus conventional glycemic control is going to improve outcomes. And so we had the UKPDS, which reported in around 1997. Then we had the DCCT, which was in type 1 diabetes, and the long-term follow-up of the DCC cohort, which is the AIIDR, which reported out in 1995. And then we know about the ACCORD trial, the ADVANCE trial, and the VADT trial. Now, as I mentioned, the study design for these landmark type 2 diabetes trials were to show whether a treatment strategy or a glycemic target, meaning either an intensive glycemic target that an A1C reduction to less than 6.5 versus an A1C of less than 8, so a difference in the A1C control, whether that would have any benefits in terms of cardiovascular outcomes or microvascular complications. And keep this in mind, because when I talk about the cardiovascular outcome trials, I'll show you what was the difference between the study design of the cardiovascular outcome trials as opposed to the landmark trials that, I've just, talked about, the UKPDS, DCCT, ADVANCE, ACCORD, and the VADT. And if we look at the summary, clearly in these trials with a intensive glycemic control, so if you look at the UKPDS, 7.9 versus 7, clearly reduced microvascular complications, both during the trial phase and also in long-term follow-up. In the DCCT and AIIDR, again, we had a reduction in microvascular complications. However, as you can see, there was no reduction in cardiovascular disease just with intensive glycemic control. In the ADVANCE, again, there was a reduction in microvascular complications. And in the VADT, we were not able to show any difference. The important thing is that intensive glycemic control clearly improves microvascular complications. However, it's only in long-term follow-up that we see that intensive glycemic control has any benefit in terms of cardiovascular disease. So clearly, improving glycemic control is going to improve retinopathy, neuropathy, nephropathy, but we don't have conclusive evidence that just intensive glycemic control is going to improve cardiovascular outcomes. So keep that in mind. Now, based on these trials, the landmark trials, we have the ABC of diabetes care, which is try and get the A1C down to less than 7%. And even in some of the younger patients, try and get it down to less than 6.5, as long as you're not increasing the risk of hypoglycemia. B stands for blood pressure, to try and get the blood pressure down to 140/90. And again, in younger patients or those who have kidney disease or they have, microalbuminuria, try and get it down to 130/80. As far as cholesterol is concerned, treat people with statins, irrespective of what the LDL cholesterol is. And if they have had a coronary event, then clearly add ezetimibe. Also, we know that fish oil, so icosapent ethyl, has been shown to reduce cardiovascular disease. And if we are still not reaching our LDL cholesterol goal, then you can add PCSK9 inhibitors. So clearly, this ABC of diabetes care, if we achieve these goals, and if we look at what has happened to diabetes complications over the years, so if you look at the population with or without diabetes, and if you look at from 1995 onwards, when the first statin trials came on and the UKPDS got reported, you can see there is a reduction in acute MI, and this is in population with or without diabetes, and reduction in stroke. If you look at population with diabetes, again, 1995 going forward, clearly there has been a reduction in cardiovascular events in people with diabetes. However, in spite of reaching that goal, you can see that there is a residual risk of people with type 2 diabetes having cardiovascular events. And this is in spite of having that A1C down to less than 7, having blood pressure control, and also being treated with statins, etc. So clearly we have made an improvement in the incidence of cardiovascular disease, but still people with diabetes are at a high residual risk in spite of achieving those goals. So keeping that in mind, let's move forward now to 2020. and look at what the ADA guidelines are. The next slide is going to be a little bit busy, but I'm just going to kind of take you, through that. So right now, if you look at the American Diabetes Association guidelines, clearly it is suggesting that treat people with obviously lifestyle changes and metformin. And once you have done that, the next thing you have to ask is this somebody who's at a high risk of cardiovascular disease or chronic kidney disease, or is there somebody who's got established, coronary artery disease or chronic kidney disease or heart failure? And if any of these if they have established cardiovascular disease or they're a high risk, meaning they're above the age of 55 and they have 50% stenosis of the coronary artery, carotid artery, or the peripheral arteries, then independent of baseline A1C, think about putting them either on a GLP-1 receptor agonist with proven cardiovascular disease benefit, and this is if they have established atherosclerotic cardiovascular disease, or independent of baseline A1C, if they have heart failure or chronic kidney disease, think about putting them on an SGLT2 inhibitor. So if you have established cardiovascular disease, which is primarily an MI or a stroke or peripheral vascular disease, or you're at a high risk, put them on a GLP-1 and then put them on an SGLT2 inhibitor if you need further glycemic control. But if you have heart failure or chronic kidney disease, then put them on an SGLT2 inhibitor. And if they cannot tolerate it, then think about putting them on a GLP-1 agonist. So what was the reason for this? And this is where, we have to look at what happened in 2008. And that in 2007, there was a meta-analysis that was published about a TZD called rosiglitazone. And in that meta-analysis that was done by Nissen, and it was a little bit flawed, and we can, I'm not going to debate that right now, but based on that meta-analysis, it was suggested that a medication that improves glucose control must meet the criteria that it is not associated with increased cardiovascular events. And the reason for that was in that meta-analysis, it was shown that rosiglitazone could be associated with some adverse cardiovascular outcomes. And so people said that, the main complication of type 2 diabetes is cardiovascular disease. So if we are going to reduce blood sugar control, which has not yet been shown to improve cardiovascular events, then at least we have to make sure that these medications are cardiovascular safe. Yeah. And at that time, there was a big uproar as to, now, a lot of new trials will have to be done. But I think eventually, it was a good thing because as I'll show, now we have some anti-hyperglycemic drugs that are showing cardiovascular benefits. So based on this, the FDA then mandated that any anti-hyperglycemic drug that is going to come into the market has to do what we call cardiovascular outcome trials to show that they are at least safe in terms of cardiovascular outcomes. And so the study design of these cardiovascular outcome trials, which is on the right side of this trial, is primarily to show cardiovascular safety and or benefit. And the difference of these trials from the initial landmark trials is that as far as the glycemic target is concerned, you want that to be the same. Yeah, so if you put the experimental arm or the placebo arm, both will have the same standard of care because you're trying to maintain glucose control, lipid control, and blood pressure control to the same extent in both the arms. The only difference is going to be that one group will get the experimental agent, the other group will get placebo. And the primary endpoint of these trials is a MACE outcome, which is cardiovascular death, non-fatal MI, or non-fatal stroke. So again, a fundamental difference in these cardiovascular outcome trials as opposed to the landmark glucose trials, because in these trials, you're not trying to cause any difference as far as the glucose target is concerned. A1C, you're trying to keep it the same between the two groups, and then you're trying to see whether there is going to be any benefit or at least, cardiovascular safety with your experimental agent. And this is a busy slide just to show you that multiple cardiovascular outcome trials have been done with DPP-4s, SGLT2 inhibitors, GLP-1 receptor agonists. Now we also have an oral GLP-1 and the newer insulins that got introduced into the market like Tresiba, that is Degludec, and Toujeo, which is the glargine U300. And then there were also some trials that were done with thiazolidine ions. And the bottom line is when you look at the meta-analysis of these GLP-1 agonist trials, and this slide shows you, the 8 trials of the new GLP-1 agonists that got introduced into the market. I'll show you in this next slide. So the Elixa is with lixisenatide, which is an Exendin 4 molecule. It's a short-acting GLP-1. Liraglutide, is a once daily GLP-1 agonist. Semaglutide is your once weekly human GLP-1. XL is the exenatide extended release, which is, in the US, it's Bydureon. Albiglutide is Stanzium. Dulaglutide is, again, once weekly. And then you have the oral semaglutide, which is Rybelsus. The main difference in these trials are that, first of all, if you look at as far as women are concerned, in majority of the trials, only 33% were women, except in the Rewind trial, which is the trial done with dulaglutide, where there were 46% women. And in terms of how many people had established cardiovascular disease. So if you look from the left to the right, in majority of these trials, 75 to 100% of the people had established cardiovascular disease, with one difference, which is the Rewind trial that was done with dulaglutide, which is the brand name is Trulicity, where only 31% had established cardiovascular disease. So, and as I mentioned, this is basically in the two groups, you have the standard of care, both in the placebo and in the experimental group. And all that you're trying to see is if you add your experimental agent and compare it to placebo, is there going to be any benefit in terms of the MACE outcomes? And the important thing is, this is again a busy slide, but just look at the heading on the top, that in these meta-analysis, clearly there is a 12% reduction in terms of major cardiovascular outcomes and cardiovascular death with the GLP-1s. Non-fatal MI is reduced by 9%, stroke is reduced by 16%. And in terms of all-cause mortality, again, a 12% reduction, and hospitalization for heart failure, 9% reduction with using these GLP-1 agonists on top of the standard of care that you're going to be doing for these patients. And so now, at least in the US, you have liraglutide that is once a week, and semaglutide, liraglutide that's once a day, and semaglutide that is once a week. That is now indicated for reducing cardiovascular events independent of A1C control in people with diabetes who've got established cardiovascular disease. And because of the group that was included in the Trulicity or the dulaglutide trial, where only 30% had established cardiovascular disease, 70% had cardiovascular risk factors, dulaglutide is now indicated for people with type 2 diabetes who have established cardiovascular disease, and also those who have multiple cardiovascular risk factors. Yeah. Now, if you look at the meta-analysis of SGLT2 inhibitor trials, I'm not going to spend too much time on this, but again, multiple trials have been done with all the new SGLT2 inhibitors that have come into the market, empagliflozin, canagliflozin, dapagliflozin, ertugliflozin. And the bottom line is, in the meta-analysis and based on what they showed in their individual trials, empagliflozin in the US is again now indicated for reduction of cardiovascular death in type 2 diabetes with established cardiovascular disease. Canagliflozin is for reduction of cardiovascular events in type 2 diabetics with established cardiovascular disease. And dapagliflozin is for the reduction of hospitalization for heart failure in established cardiovascular disease or multiple cardiovascular risk factors in people with type 2 diabetes. And you're going to hear more about this, I think, in some of the topics that are going to be discussed by Dr. Kuhadia and Dr. Butler, in this same conference. SGLT2 inhibitors, interestingly, have also been used in non-diabetics, and dapagliflozin, has been shown to have benefits in both non-diabetics and diabetics with heart failure and reduced ejection fraction. And again, I think Dr. Butler is going to be talking about this. Now, what about thiazolidine ions? And pioglitazone, which is Actos, has been used. And I'll show you the meta-analysis of the cardiovascular outcome trials with thiazolidine ions. These are, again, very good medications that improve glucose control. Unfortunately, went out of favor once Nissen, came out with its meta-analysis. But if you look at thiazolidine ions, which are generics and don't cost as much as the GLP-1 agonists and the SGLT2 inhibitors, again, in the heading out here, you can see that cardiovascular benefits in established cardiovascular disease, pioglitazone shows a 20% reduction, in MACE events, although there is some increase in heart failure and there is no evidence of benefit in terms of mortality. So if you look at the MACE in the meta-analysis in the secondary prevention group, the odds ratio is 0.79, which is a 21%, 21% reduction in cardiovascular, composite endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke. So in somebody who has established cardiovascular disease, again, pioglitazone has been shown to reduce MACE events. And as you know, pioglitazone has also been shown to reduce, MACE events in non-diabetics. So these were pre-diabetics who've had an ischemic stroke or a TIA, and that was the IRIS trial. I've given you the, the reference out there if you want to look at it. Again, a hazard ratio of 0.76, so 24% reduction, in terms of MACE events in people, non-diabetics. So these were pre-diabetics who had a stroke or a TIA. So clearly now there are 3 anti-hyperglycemic therapies that have been shown to have cardiovascular benefits, the GLP-1 agonist, SGLT2 inhibitors, and the TZDs. And that brings me back to why the American Diabetes Association now has suggested that if you have somebody with type 2 diabetes and if they have established cardiovascular disease or they're at high risk of developing cardiovascular disease, then please put them on a GLP-1 agonist, which has the labeled indication if they have atherosclerotic cardiovascular disease, or put them on an SGLT2 inhibitor if they have heart failure or CKD. And that is independent of baseline A1C, because you want to then kind of, reduce, the residual risk that these people have, in spite of putting them on all the, in spite of intensive glycemic control, statins, ACE inhibitors, ARBs, etc. Now, once these trials came out, there was some discussion about what could be the mechanisms. And what I'm going to do is primarily, concentrate on the mechanisms of the GLP-1 agonist, although I'm just kind of showing you this as to what is the putative mechanism for SGLT2 inhibition. Clearly, there is diuresis with these medications. There is sodium loss. They also have a secondary effect as far as blood pressure lowering is concerned. There is weight loss. If you reduce albuminuria and slow down kidney function, again, chronic kidney disease increases cardiovascular events, so that could also factor in. Clearly, there is a change in the myocardial metabolism, a shift towards more ketone-based metabolism. There could be blockage of the sodium hydrogen cotransporter, and also reduction in sympathetic tone, because what we know is that these medications reduce blood pressure but do not increase heart rate. So there could be some reduction in sympathetic tone that could be beneficial in terms of sudden death, etc. As far as the GLP-1 agonists are concerned, apart from lowering blood sugar and also causing weight loss, which we know, GLP-1 agonists have also been shown to reduce, slightly they reduce, blood pressure. And again, that could be beneficial. And also I will kind of concentrate on, the anti-inflammatory action of GLP-1 agonists to show you how, if they have an anti-inflammatory action, how they could be beneficial in terms of reducing cardiovascular events. And before I go on to the studies that have been done in our department, just want to share with you some slides about the association of inflammation and atherosclerosis. And if you look at a plaque, as far as, the atherosclerotic plaque, which happens in people with coronary artery disease, you will see that this plaque has T lymphocytes and macrophages, So again, histologically, you can see that they are kind of behaving like, what happens in a chronic inflammatory disease like tuberculosis, etc. So when you have a chronic inflammatory disease, obviously there is accumulation of macrophages and mononuclear inflammatory cells. And if you look at the histology of the plaque, clearly there is an accumulation of mononuclear cells and macrophages, which then get laden with lipids, and ultimately, that fibrous cap, kind of breaks, and then there is thrombosis and, platelet aggregation out there, and that causes myocardial infarction. Now, the inflammatory mediators that are involved in this, clearly there is reduced nitric oxide, there is, ICAM1 that increases. So now these mononuclear cells can stick to the endothelium. And once they stick into the endothelium, these matrix metalloproteinases then break the endothelium, and let these mononuclear cells go into the subintima. Then there is monocyte chemoattractant protein 1 that attracts more mononuclear cells. There is an inflammatory cascade that is set up by TNF-alpha IL-6, and ultimately there is plaque rupture with MMP, and then there is thrombosis with tissue factor and PI1. I'm not going to go through this NF-kappa B mechanism, but I'll also show you that ultimately nitric oxide that is involved in improving endothelial function works through cGMP, which is cyclic GMP, and prostaglandins that also cause vasodilation works through cyclic AMP. And the reason for doing this is because when I show you the GLP-1 trials that have been done with this in our department, I'll show you what effect these GLP-1 agonists have on NF-kappa B, which is an inflammatory factor, which is a transcription factor for most of the inflammatory genes. What happens to the oxidative oxygen-free radicals then can also induce NF-kappa B and also cause lipid oxidation, and then what effect they have on cyclic GMP and cyclic AMP. And to go through this, first of all, I'm just going to show you this slide, which we published in 2012 under the leadership of Dr. Dandona, and I'll show you, and I'll talk to you about my team, where we took people with type 2 diabetes who were on insulin, and we put them on exenatide, which is exenatide is a short-acting form of Bydureon, which is extended release. And we clearly showed that if you give somebody exenatide 10 micrograms twice a day, for 12 weeks, there is a reduction in reactive oxygen species generation as opposed to what happens in placebo. This is what we showed as far as NF-kappa B is concerned, that if you give exenatide, there is a reduction in our NF-kappa B over 12 weeks. And NF-kappa B, as I mentioned, is the transcription factor for a lot of the inflammatory genes. So if you reduce NF-kappa B, you will probably reduce those inflammatory genes, and that would then also have an effect as far as atherosclerotic disease is concerned. This is the acute effect of exenatide 5 micrograms, because exenatide also causes some weight loss and glucose lowering. So we also wanted to show what was going to happen if we just give one injection of exenatide and look at it, what happens over 6 hours. Exenatide peak is at 2 hours. So again, you can see, a reduction in NF-kappa B that is happening within 2 hours of giving exenatide. This is with TNF-alpha. This is with IL-1 beta. These are all inflammatory cytokines. This is, a Western blot of some inflammatory proteins. Again, a reduction in MCP1, a reduction in MMP9, again, a reduction in plasma IL-6. And then we also looked at what happens to plasma cyclic GMP, plasma cyclic AMP, atrial natriuretic peptide, and angiotensinogen. And again, you can see that exenatide is increasing cyclic GMP, cyclic AMP, which will then have an important role in terms of vasodilatation and endothelial function. ANP also will have an effect as far as vasodilatation is concerned. And clearly there was some also changes in plasma angiotensinogen. There was a reduction in plasma renin, reduction in plasma angiotensin 2, no change in plasma aldosterone, and then there was some effect on TGF beta 1. So if we look at atherosclerosis as an inflammatory disease and understand what the role of inflammation, what the role of these vasodilators are in terms of an endothelial function, and what is the role of MCP1, MMPs, etc. in this disease cascade, then we can understand how GLP-1s can have an improvement in cardiovascular benefit independent of glycemic control. And we have done similar studies with dapagliflozin, which is the SGLT2 inhibitor, again showing a reduction in angiotensin 2, increase in AMP, increase in cyclic GMP. And in terms of thiazolidine ions, again, we have shown this was done with troglitazone, which, as you know, is a thiazolidine ion. Now it's not there for use, but again, we showed with troglitazone there was a reduction in ROS generation and also an improvement in brachial vasodilatation post ischemia, which is a reflection of endothelial function. So again, we have these mechanisms through the, some of this obviously has been done in our department and some has been done other departments, showing that GLP-1s do have, an effect as far as inflammation is concerned and also an effect as far as the vasodilatory functions are concerned, which could then make us understand why these medications could be beneficial independent of glycemic control in people with cardiovascular disease. So to finish, I would just like to say that intensive glycemic control has clearly not convincingly reduced cardiovascular events, although they're important for reducing microvascular outcomes. We have, based on SGLT2 inhibitors and GLP-1s and TZDs, that improve cardiovascular outcomes independent of A1Cs. Clearly, SGLT2 inhibitors are more important in heart failure and cardiovascular and chronic kidney disease outcomes, while GLP-1s have been shown more in atherosclerotic cardiovascular disease. And as these are cardiovascular disease and chronic kidney disease are the major cause of mortality and morbidity in type 2, we need to use these medications independent of A1C to reduce the residual risk of cardiovascular benefits. And don't forget, standard treatment is still very important because this is all on top of standard of care. And before I finish, I just want to show you the team. Clearly, who have done most of this work: Hussam Ghanem, Jean, who's our research nurse; Kelly Green, who's our research lab technician; Sana, who's also in the research lab; and clearly Dr. Dandona is my mentor, who has done most of these. All these studies were done under their leadership. And this is our other group who were involved in this: Nitesh Kohadia. He's from Gujarat, and I think he'll be speaking to you later on. He was one of the fellows in our department and also an attending physician before he left. And then you have Dr. Megdisi, Dr. Batra, and myself on the left out here. So again, thank you for your attention. And, I'll take any questions if you have any. Again, thank you.
Dr. Chaudhuri, it was a wonderful presentation. And it is a hot topic regarding the CV benefits of all the anti-diabetic drugs. Now, there are a few questions we can
take it now. We can take it.
Yeah,
now,
we can take
please.
it now only.
And sir was so generous that he started replying. But as you take it orally, so
Oh, he's already sir.
Well, I did not know what the system was.
So if you have seen it, do you want a specific question that you would like to answer, Dr. Chaudhuri?
No, I think all these questions, so I'll just kind of go through. So the first question was about, what about the cardiovascular benefits of acarbose? Clearly acarbose initially had shown benefits in terms of cardiovascular outcomes, has not really met the rigor of all the other cardiovascular outcome trials that we have seen, has not made it to the guidelines. In the US, at least, now we have started using acarbose, especially because of the cost, perspective, but, it really has not met the rigor of some of the other cardiovascular outcome trials. The sulfonylureas, again, I think they are safe in terms of cardiovascular safety, but clearly we don't have any cardiovascular benefit. Again, cost is an issue with some of these newer anti-hyperglycemic drugs. So where cost is an issue, then, you use those medications to reduce glucose. We tend to use it in small doses in combination with other medications that are not very costly so that we can improve glycemic control and not cause hypoglycemia. And again, I would kind of really talk about TZDs because, they are generic. I think, as I showed you, 20% reduction in cardiovascular events in people with established cardiovascular disease obviously don't have the mortality data, does increase heart failure. But we have really under the, again, in our group, we use TZDs, very, very commonly. The oral semaglutide, we have cardiovascular safety data on the basis of the trials that they have done. We don't have any trial showing cardiovascular benefits, but these trials are ongoing. And the same thing as, I think there was a question about gliclazide, that was used in the advanced trial. And really, again, they are safe in terms of cardiovascular safety, but we don't have any cardiovascular benefit with these medications. Yeah.
Thank you very much, Dr. Chaudhuri.